now get something called a PEG tube that's direct surgically implanted into the stomach, but maybe they can't have surgery right then for some reason, so they want to wait. So they might temporarily put it down into the stomach. The other reason is if someone has a bowel obstruction and they need to, you'll hear people talk about giving their bowels some a rest. They'll insert an NG tube because it goes directly into the stomach, and then it will take the stomach contents out. It will bring them out into this container. Now for validations, this will already be all set up. You don't have to know about all that. But typically when you're at the hospital, you'll go to the supply cart and you'll get your NG tube, which y'all do have this in your skills pack. You're gonna get a piston syringe, which y'all have that in your skills pack. It has a little container that it sits down into. Off the cart, you will get this suction canister, suction tubing, which it'll be in a little package like this. And then this little pinkish is directly connected to the suction, and on top of the canister it says patient. That's where you put one end of the suction tubing and the other one is going to go connect to the NG tube. So once you get it inserted, then you're not going to connect it to the suction until you know that it's in place, okay? And I'll go through, there's 3 ways you can do that. I'll go through that. But usually once I get my order on my patient, before I ever go in there with a bunch of supplies and then look at me like, what are you fixing to do to me? I go in there and tell them, you know, Ms. Jones, your doctor's ordered for you to have an NG tube, explain why. And then I go get my supplies, and then I'll come in. So you always want to make sure that the bed with any procedure you do is at your level, you know, that you feel comfortable. Taller people, it's going to be up a little more. Shorter people, down a little bit more. Typically when I'm going to have an NG tube, I'll put a towel across their chest, just, you know, because I want to try not to get anything on their gown. I've already checked my order. I would always come in and do my 2 patient identifiers. I would check the armband. I would ask the patient their name and date of birth. That's my 2 patient identifiers. Usually we'll ask the patient, you know, maybe if they've ever had sinus surgery, broken their nose, do they have a deviated septum. I would get my pen light out and I would look in both my nares to make sure there's no obstruction or any reason why I could not get that NG tube down. In all of the mannequins here, we go down the right side. Okay, you will not be able to get NG tube down the left side. So mannequins, we always use the right side. You always want to have an assistant. This is kind of something you don't want to try to do on your own because you need your assistant sometimes to help with positioning the head. And as they're swallowing, as I'm inserting the tube, I'm going to have an assistant either to give them sips of water or ice chips. Because I'm going to be, you know, I'm going to get to a point where as they're swallowing, I'm getting that tube down. So, I need KY jelly or whatever lubricant the hospital uses. I've got my syringe. They do have, a lot of the facilities now have these little strips that look like the anti-snore strips that you can look at it where you can put the tube in. There's a certain way we use tape to anchor it, but tape irritates a lot of people's skin, so this is something you could use. So before I get started, I've already decided I'm going to put it down the right side. I'm going to get my tape ready. Now this is not a sterile procedure, so I can just put on regular gloves. And I'm also going to get my tape ready. This my nice assistant here has gotten done for me. So you're going to tear a piece off that's going to have you're going to tear it down the middle. Part of it's going to go across the bridge of the nose. The other part I'm going to show you is going to kind of anchor it. I'm going to say I've gotten an alcohol swab and I've cleaned off my bedside table. I'm going to put it there. You also can put it on your gloves. You also can open up this, even though this is not sterile, it's clean. You can put it on this paper as well too. Now, did anybody read or see the videos about how high do I need to have the patient to put one down? Okay, just thinking about it. How high would I want my patient?
Your
I
level?
want them to be sitting up, like you don't
Yeah.
want them to be down.
Right. Why? Why wouldn't I want them down?
What if they choke?
Yes. If I'm trying to put a tube down somebody that's vomiting and I've got them flat, they're going to aspirate more than likely. They're going to bring something up from their stomach down their lungs. I'm going to be in trouble. You want them at a 90-degree angle. Now, a lot of people can't sit at 90 degrees, but you want their head as high as possible, okay? And it's just going to help the ease, you know, it's downward, so it's just going to help that ease go down. In this week's folder, I put a paper in there called Fowler's Positioning. When you hear the term Fowler's Positioning, that's kind of Fowler's as a whole. It can be from 30 degrees to 90 degrees. High Fowler's is 90 degrees. If you see the term semi-Fowler's, that would be half of the high, 45 degrees. Some books will use the term standard Fowler's, that's 60 degrees, head of the bed, 60 degrees. Low Fowler's is 30. So low is 30, semi 45, standard 60, high Fowler's is 90 degrees. So I've got him as high as I can. How am I going to know how far to put it down?
Mark your tube from the tip of the nose to the xiphoid process and then to the bottom of the sternum.
Okay, so tip of the nose, and then where would I go? I'll do it up here so y'all can see it.
Is xiphoid process?
Is there somewhere I got to go before I go to the xiphoid?
Put it here.
Yeah, the lower lobe of the ear. Now, you don't have to stretch it out, you know, real tight, but you don't want it looped. So I'm just going to say the tip of the nose to the lobe, lower lobe. Then I'm going to go down to the xiphoid, bottom of the xiphoid process. Most facilities, most nurses, you'll see them put a piece of tape around where they're supposed to do that. Now, you always want to make sure you turn your edges down on this piece of tape, because if you don't and you stick both sides together, you'll never be able to get it off. So this way I could remove it, you know. But most nurses will leave that on because if it were to start coming out, it kind of gives you a guide to know.
Do you tell your patients, like normally, like as they're watching you do this, like, yeah, I gotta put all this inside of you, bro?
Yeah, when I go in to tell my patient what I'm doing, I tell them it's not a painful procedure, but it's going to be uncomfortable.
Yeah.
If they're vomiting profusely, they're going to feel so much better when you get down, because you'll know when you're in the stomach because you'll start seeing stomach contents come back real quick. I still remember the first one I put in. The lady started tearing up. I started crying. And when it was over with, she said, and she calmed down, she goes, what? Oh, I feel so much better. She goes, why were you crying? I said, because you were crying. You know, it was my first one. I was petrified. And, you know, and then we had a good laugh about it, you know. But, you know, I let them know it's uncomfortable. I'm going to get you to swallow. That's going to help. You know, I'm not going to go in there all doom and, oh, this is going to be the most horrible thing you've ever been through, you know. But I do like to tell them.
Good word she used, uncomfortable. Because they're going to ask you, is this going to hurt? Guarantee you they're going to ask you this. And you don't want to lie to them because it probably is going to
No.
hurt a little. It's
And
going to be
it's
uncomfortable.
it's a fairly quick.
Yeah.
Fairly quick procedure. So I'm going to give you some troubleshooting things to if happens. Now, when you get this out of the pack, this little piece right here is a very, very, very important piece of equipment, because you have to have this piece to connect the tube and the suction. And I'll show you that in a minute. Sometimes you'll go in a room and you'll see it an extra one taped to the wall. These will get lost in the bed. You know, they're white.
They need to
Up
be
against
hunter
that linen.
orange.
Yeah.
That's
I
what the
mean,
color needs to be.
so if you have to unhook it, put it somewhere where you know where it is. You know, it's kind of do that in every room so you know.
You're guessing
Now-
this and you can't find it.
Oh, I know. It'll get up under the patient, they'll be on it, you know. This is an air vent. The air vent, if you pull it back, you'll see there's a little valve right there. When this is hooked to suction, this air vent has to be open for the suction to work. So I don't have it hooked to suction right now, so I'm just gonna kind of put it right here while I'm inserting it so it's not flapping around. But anytime it is to suction, that has to be free. You can't aspirate anything from this. You can only aspirate stomach contents and do tube feedings through here. Nothing ever through the area. Okay? So, I've measured, have it here. I have my assistant. When the patient first starts, I'm going to have their head, ask them to have their head back on the pillow. Okay? So again, I've already noticed that I'm going to do my right. I'm going to, now, you're going to start at the floor of the nose. If you start up, you're going to scrape down. It's going to make them cough, eyes water. And I usually will try to bend because I want it going downward. So you want to kind of bend it and get it started at the bottom. Now, as I start, when they start coughing, it's reached the pharynx, okay? Once they do that, you're going to ask them to bend their head forward. Now, you're not going to have them say, please put your chin on your chest. You just want them forward enough that it opens up so you can be able to get it down. That's the point where you're going to have them take ice chips or drink water. You know, it kind of depends on the facility. I used to always do ice chips. To me, it takes longer to do ice chips because they have to melt for them to swallow. Water, they can take a sip and swallow. So as they swallow, you're going to insert. When they stop to take a breath, you stop. Once you hit the pharynx and you start going down, the coughing should stop. If it does not, you can get your pen light. You can look in the back of the throat and make sure that the tube is not coiled in the back. If it's not and they're still, don't take this out because you know you've kind of got through the worst part. You don't want to try to take it out if possible. Pull back a little bit to make sure it hasn't gone down the lung. If they're still coughing, pull back a little more till they quit coughing. Give them a little time to recover. Typically, if they're swallowing and you're doing it as they're swallowing and you stop when they stop, it typically does not go down in the lung. Okay? So they're going to keep swallowing. You're going to get it down. Now, in the mannequins, sometimes we've done it so much they don't want to take it. Now, you're never going to turn a patient's head like this.
This one's a little stiff.
Yeah. Okay. So that's about all I can get it in. Okay. So look, I got it there. Okay. So now I've got to check it. I'm not going to tape it to their ear everywhere till I make sure. So what I can do is to take that piece that I split and I'm going to put across the bridge of their nose. I'm going to take one piece and go around the tube and then the other piece the other way. Because if I don't, that patient starts vomiting violently, it's going to come out. If I've got a combative patient and I turn around, they're going to yank it out. So, that was a lot to get in. I want to make sure that baby's not going anywhere, okay? Still not going to hook it up to suction. The 3 ways, the only way to 100% know, and I forgot to tell y'all, 2 to 4 inches that you put in KY jelly before you inject it, okay? I mean, insert it.
2 to 4 inches on the end.
I'm
Yeah.
sorry?
Yeah, you lubricate it 2 to 4
Yeah,
inches.
you lubricate
okay.
2 to 4
Yeah,
inches.
From the end.
From the end. The only way to 100% know is an x-ray. Now, if the patient is vomiting, I'm going to know it's in the stomach if I start getting stomach contents back, which if they're violently vomiting, you're going to get it back pretty quick. I've had a patient before that I had to connect very quickly because it was coming back so fast, and I got like 500 milliliters just like that out. They had so much in their stomach. So they don't always order an x-ray in that case. If they have it inserted for a tube feeding, they're going to order an x-ray because if this tip is not in the stomach and I start getting tube feeding, it's in the lungs, what's going to happen?
It's gonna cough.
Hmm?
It's gonna hurt. They're gonna start coughing.
They're going to aspirate. They're going to start getting tube feeding into their lungs. They're going to start coughing, getting short of breath. They're going to get into distress.
Really cough.
Really
Real
cough.
cough.
So the only 100% way to know is to do an x-ray. The other thing I can do, the units, this is called a piston syringe. Remember the syringe upstairs we used for injection was a lure lock, where you had to go down a little track. This is called a slip tip, and it's different than the other. So this is called a slip tip, but it's a piston syringe. You can put that in there, and I can pull back a little stomach contents, 5 to 10 milliliters. I wouldn't pull back more than 5 to more than 10. I'm going to put that back because it's probably still coming out. The units will have little packs of pH paper. You put that over the pH paper. Remember from A&P, gastric contents are very acidic. Anybody remember what pH should be normally? It's on your validation rubric if you think. 3.5 to 5.5. 3 point, yeah, that's good. 3.5 to 5.5 kind of range. So you kind of follow what the color, the paper color, and compare it to the little packet. The other way you can check is to put about 30 millimeters, 20 to 30 millimeters of air in your syringe. I'm going to take my stethoscope over the stomach area, and I would listen, and I would very quickly inject my air, and I would be able to hear a whoosh. You won't hear that on the mannequins, but over a patient you could hear the whoosh. That is not used as much anymore. It's the pH paper and the x-ray, but you may be in a long-term care facility where they don't have pH paper, you know, whatever. So you can do that. So now, let's say I've gotten everything back. I know it's in there. I'm going to connect to suction. I'm going to take my air vent because I know I've got to leave that open when it's connected to suction. So I'm going to connect here. Again, you would not be able to connect without that little piece. Okay? So these will not turn on, but in the hospital, you're going to have, you want this 0 to 80 millimeters. That's your green. You see green, yellow, red. The green is 0 to 80 millimeters of mercury. That, if you get in the yellow or red, it's too much suction. So the doctors will usually order insert NG tube or NGT, nasal gastric tube, to low suction, and that's your green area. So, you know, you just kind of keep that on. Now, sometimes a doctor will come in and say, I think they're getting better. Let's clamp the tube for 2 hours and then connect it back and see how much, you know, see kind of how they're doing. So some facilities will actually have a clamp that you can put on there, or they'll have some kind of apparatus that you can. What you might do is just have this, which I think I put in there too tight. You might just kind of leave that off and leave the suction off. Go back in 2 hours, connect them back, and see how much comes out. When you're getting ready to take it out, you first would turn off your suction. You would, this would still be here, that would be open. You would undo. Now when you're taking it out, they don't have to be at 90, they could be 45. Half that, like semi-Fowler's positioning. Probably would still get a towel, just in case. I, of course, would untape everything. I'm going to have my patient take a couple of big breaths. And when I tell them when you get to that third breath, hold it. And right when they're starting to hold, I take it out. Unless there's blood on this, it can go into a regular trash. If it does have blood, you can put into a red bag.